Children's Medical Center Hospital, and I'm usually treating the patient with primary immunodeficiency diseases and allergic diseases. So we have already learned about the immune system, and we know that the immune system is responsible for fighting against the pathogens and enemies. And now today I have 3 classes with you, and it's about the diseases of the immune system. So I'm talking about the diseases that the immune system can suffer. So you know that there are different systems in human, like gastrointestinal system, respiratory tract system, central nervous system, and the immune system. So each system could have some disorders. And if you imagine the body as a country, so the immune system is responsible for protecting the whole country against the enemies. So please imagine that the immune system can get some diseases. The first part, the one side is immunodeficiencies. It means that the country has lack of soldiers and cannot fight with the enemies. So what will be happen? So if you have not enough soldiers in the country, what will happen? They can come and get some parts of the country, okay? So it could be divided into 2 groups of primary and secondary. Primary means it's genetic disorders, and the countries, the human, has no soldiers, no immune cells from the beginning, from the birth, okay? So this is primary immunodeficiency diseases that I will discuss in the next session. And there are more than 500 different types of diseases. This is primary immunodeficiencies. And we have secondary immunodeficiency. What does it mean?
When we get some disease and our immune cells get targeted or killed, then we get...
Please let me do some examples.
For example, AIDS.
HIV infection that could destroy the CD4 positive cells and make AIDS. What else? What else? Secondary immunodeficiencies.
Maybe any cancer, carcinoma in the immune system.
Cancer, metastasis, and treatment for cancers like radiation, chemotherapy, just suppress the immune system. What else? Corticosteroid therapy, you just suppress the immune system. Splenectomy,
Rheumatoid arthritis.
autoimmune encephalopathy, so you lose the antibodies. Okay, so this is secondary immunodeficiencies. And this, again, imagine that some countries have not enough soldiers, like, some countries, neighboring countries like Iraq, Syria, Lebanon, even Palestine. You can see that it's lack of the immune system, so the enemies could come and get some parts of the country. This is immunodeficiencies. In another side, we have hypersensitivity disorders. What does it mean?
Overactivation of immune system.
Okay. So you are, for example, you are from different countries. You are mainly from Kashmir, Iraq, what else? Pakistan. So they are mainly from Pakistan,
India.
Kashmir, and Iraq, India. Okay. So if you are walking in the streets in the Kish Island, you might face some people that just shake your hand. What they are they from Iran? Okay, this is hypersensitivity reaction. When you come to Tehran to continue your study, you might see in the campus that some Iranian people just say, who are they? Are they from Iran? Are they from the countries? And it's also true when we travel to your country. Please imagine a Japanese, European guy come to your countries, okay? You just shake your hand, who is that guy? So they are human, they are not enemies, okay? But this is hypersensitivity reaction. Why it will happen? Because you do not face such people in the kindergarten, so you didn't make any tolerance. So when at the university, adulthood, you face some people, you make hypersensitivity reaction. This is type 1 hypersensitivity, allergic reaction to some people who are not pathogens, who are not enemies, but you make some reaction. another type of hypersensitivity. We have in each country, okay? For example, are you all Muslim?
Yes.
So you see that, I mean, there are some people, Shia against Sunni, Sunni against Shia, so you are both Muslim, okay? This is autoimmunity. So you can face some problems in Iran, in Iraq, in Syria, even in India, Kashmir, okay? So it's one country, but they make some autoantibody against each other. So I face that my joint is not mine. So I make some autoantibody against my joint. It's arthritis. Against my central nervous system, it makes multiple sclerosis. Against the endocrine, it makes diabetes mellitus. Okay? So again, all of these are some kind of hypersensitivity disorder, but autoimmunity. Is it clear?
Yes.
So I'm planning to discuss about these types of disorders, and I just started with some simple examples. So I would like to acknowledge Professor Masoud. When I was a medical student at Tehran University of Medical Sciences, he was the guy who taught me the hypersensitivity, but unfortunately he passed away just a decade ago, and after that it's my job to discuss about hypersensitivity disorders. And I would like to show you a few examples of the hypersensitivity. You can see that the girl who has some kind of rhinola, sneezing. The second one, you can see some dermatological manifestation. The third one, some kind of edema, some problems in breathing. The fourth one is a boy who faced some problems after, eating or biting some peanut cookie. And the last one is a girl who has some problems in breathing, just has some tachycardia and respiratory distress. The second slide, top left, you can see that the girl has some kind of ptosis. You can see that eye. The next one has some problems in the oral cavity, mucosal, some bullous lesion in the oral cavity and the skin and mucosal line. The third one, top right, is a case with some problems in joint, heart, and you can see malalash in the skin. Okay, in the face, you can see that has some kind of malalash. The next one is the lady with exophthalmy. She has she has some nervous problem and has exophthalmia. The next one has some joint deformity, and the last one you can see again some dermatological problems. At the end of the class, I will get back to this slide, and I expect you to let me know that each case has which type of hypersensitivity and which disease. Okay? So I mentioned some points about the hypersensitivity disorders, but I should mention that hypersensitivity has 4 types. Type 1 hypersensitivity is immediate hypersensitivity, and it's IgE mediated. T helper 2 has the main role in type 1 hypersensitivity. Okay? All allergic diseases belongs to type 1 hypersensitivity. Type 2 and type 3 both are antibody mediated, but in type 2, antibody attached to the surface of a cell or tissue and make reaction, but in type 3, we have antigen antibody immune complex. It goes to the small vessels, and then we have reactions. Is it clear? In type 4, this is cell-mediated immunity, delayed type hypersensitivity, and Th1, Th17, and CD8 positive cells have the main role in type 4 hypersensitivity. Was it clear? Are you sure? Okay. So type 1 hypersensitivity is immediate reaction, IgE, and T helper 1 has the main role. Okay, is it true?
T helper 2.
So why you just shake your head? It was not true. T helper 2 has the main role. So what was the difference between type 2 and type 3?
Like the antibody directly attaches in type 2 and type 3.
Exactly. In type 2, antibody attached to the surface of a cell or tissue and make reaction, but in type 3 we have antigen antibody immune complex. It goes to the small vessel and then we have reaction. In type 4, this is cell-mediated immunity, and Th1, Th2 and CD8 positive cells have the main role. Is it true? No.
CD4 and
CD8.
CD8. CD4 as a
Would you like to have a look again at this table? Th1, Th17 and CD8 positive cells. But in type 1, T helper 2. Okay? Is it clear? Okay. Let's start with type 1 hypersensitivity. Please imagine that this is a mast cell. What's this? What's this?
type 2.
No, what's this? No, this is mast cell. What's this?
Histamine
This is granule
containing
histamine. Okay? So this is Fc epsilon receptor and IgE attached to Fc epsilon receptor from the variable lesion. Okay? Is it variable lesion?
yes
Fc is constant lesion. This is Fc epsilon receptor and this is Fc, constant lesion. Okay, so variable lesion is free. So allergen attached to the variable lesion of the IgE, then we have some deformity at the shape of the mast cell, then we have histamine release. That's why we prescribe antihistamine for those who are suffering from type 1 hypersensitivity allergic diseases. So when you are crossing a street with some pollen, you start rhinola, sneezing immediately because of type 1 hypersensitivity. But if you go away from that sleep, your symptoms and signs will be continued. Am I right? So this is because of some cytokines like TNF-alpha, IL-3, IL-4, IL-5. So you continue for a few hours for rhinola. Do you remember TNF-alpha belongs to which type of cytokines? Pro-inflammatory cytokine. What else? Pro-inflammatory. TNF-alpha, IL-1, IL-6, okay, and TNF-alpha. So they are pro-inflammatory cytokines. And depends on the reaction in different organs. We have different types of allergies. For example, if we face some allergic reaction in lung, we say allergic asthma. So if we face in nose,
rhinitis,
rhinitis, allergic rhinitis. In eye, iitis.
Conjunctivitis.
Conjunctivitis. In gastrointestinal system, food allergy. In the skin, dermatitis, we could say either eczema or urticaria. So what's the difference between eczema and urticaria? No? No idea? Do you know what's eczema? No? Didn't you face any time with some skin lesion, with pruritus, rash? So this is eczema. Okay, what's urticaria? No idea? In Farsi we say kahir. So urticaria, when you have some bite of insect, you can see that there are some redness. Okay, this is urticaria. And the difference between eczema and urticaria, in eczema, this is the skin is coarse. Okay, but in urticaria, the skin is firm. So this is the difference between eczema and urticaria. So about the allergies, it seems that pollen, food, and blood are the main types of main causes of allergens. So, have you ever faced any kind of allergic reaction like allergic rhinitis?
Yes.
How many of you? 1, 2, 3. How many of you are suffering from some kind of food allergy to egg, kiwi, tomato? No? Okay. How many of you have faced some kind of eczema, rashes, or 1? Okay. 4. And you? And did you also suffer from allergic rhinitis from the first group or not? Okay, 5. 3 plus 2, 5. And you are 2, 4, 6, 8, 10, 11. So it's about 50%. So your book, it has been mentioned that 1/3 of the population are suffering from some kind of type 1 hypersensitivity. In all my classes during last 10 years, when I went to the class and asked such kind of question, more than 40% of the people have suffered from type 1 hypersensitivity. And this is only type 1 hypersensitivity, not type 2, type 3, type 4, immunodeficiencies, okay? So it seems that the immunological diseases are the most common diseases in the world because about 50% of the people are suffering from such kind of allergic reaction. So to have better idea about the mechanism of type 1 hypersensitivity, please imagine that the allergen or pollen cross the mucosal line. Okay? The dendritic cell get the allergen and present it to naive cell. What's the role of dendritic cell? A, B, C. A, B, C. APC, antigen presenting cell. So dendritic cell present allergen to naive T cell. Naive T cell promote to Th1 and produce IL-4. B cell proliferate to plasma cell to produce IgE. IgE from constant lesion attached to the FCF receptor, and the mast cell is sensitized. Was it true?
Yes.
Are you sure? When I'm asking you such question like this, it means that there are some mistake in my sentence.
Like variable frequency.
Would you like to repeat it?
Yes.
Would you expect me to repeat?
Yes.
Yes.
Okay. Please make attention. Allergen cross the mucosal line. Dendritic cell as antigen presenting cells presenting to the naive T cell. Naive T cell promote to Th1 to produce IL-4. B cell stimulate and proliferate to the plasma cell to produce IgE. IgE from the constant lesion attached to the FCF receptor at the surface of the mast cell, and mast cell gets sensitized. Was it true or false? Exactly. Not Th1. I'm talking about type 1 hypersensitivity. And I mentioned that here it should be TLPL 2, not Th1. Exactly. Thank you. So when we suffer from the second exposure, now the mast cell is sensitized. At the second exposure, you can see that it attached to the variable lesion of the IgE. We have some change at the surface of the mast cell. We have vasoactive amine release like histamine. We have immediate reaction, and the cytokine lead to late phase of the reaction, 2 to 4 hours later.
Sir, what is the role of TLP2 in this reaction?
Producing IL-4.
Only TLP2 can produce interleukin 2.
For in type 1 hypersensitivity, yes. Other cells can produce, but in type 1, in type 1 hypersensitivity, TLP2 has this role. So what will happen after we have histamine release. So release of histamine in vessels leads to vasodilation and hypertension. Okay? Are you sure? This is a tube. When we have vasodilation, this is physics.
Tension will be low.
The tension
Decrease.
decreases, not hypertension, hypotension. So we have vasodilation, vascular leak, and hypertension. Okay? And we have bronchoconstriction. So the respiratory system constrict. So that's why the patient who are suffering from asthma, we suggest salbutamol. This is the spray blue one as a bronchodilator, because they have some respiratory tract distress. This is bronchoconstriction. So it leads to vasodilation, vascular leak, bronchoconstriction, and intestinal hypermotility would also be happen in patient with type 1 hypersensitivity. I mentioned some diseases in local form of allergic. I should also mention that we have a systemic form of the type 1 hypersensitivity. We mentioned anaphylaxis. In anaphylaxis, this is emergency medicine. So if we do not, so by the case with type 1 hypersensitivity, a systemic form of the type 1 hypersensitivity, the patient will die soon, in 30 minutes. Why? Because there is general histamine release, general vasodilation, and severe hypertension. Okay? So all vessels are getting dilated and then get clamped and no pressure, so the patient will die in anaphylaxis. So it seems that both host factors and environmental factors have role. It means that genetics, polymorphism, and also some environmental factors like pollution, cigarette, and some hygiene problem could lead to some forms of type 1 hypersensitivity. Do you know the difference between mast cells, basophils, and eosinophils? You know?
Yes, sir.
Okay, you know that the mast cells are in circulation, but basophils and neutrophils are in connective tissues.
No, sir, no.
Mast cell in
Basophil in blood circulation. Reverse.
So the major site of maturation in mast cells are connective tissues, but in basophils and eosinophils, the major sites of the maturation are bone marrow, and then released to the circulation. It seems that the lifespan of the basophil is much lower, days, in eosinophils days to weeks, and mast cells could be alive for weeks to months. IL-3 is responsible for developmental basophil and mast cells, but IL-5 is responsible for maturation of the eosinophil. FGF0 receptor, which is responsible for type 1 hypersensitivity, can be detected at the surface of mast cells and basophils, but not eosinophils. Histamine could also be released by mast cells and basophils, not eosinophils.
Sir, can you repeat second one?
What?
Second one, can you repeat the expression of FC?
Expression of FGF0 receptor is just at the surface of mast cells and basophils, not eosinophils. Okay?
So,
And histamine can be released by mast cells and basophils. So when I'm talking about type 1 hypersensitivity, it's because of mast cells and basophils, not eosinophils. It has no role in type 1 hypersensitivity. Okay. I think it was clear. Are you happy?
Yes.
Okay, so please have a look at an animation of type 1 hypersensitivity. IgE mediated hypersensitivity. All of the following are needed except APC. Do we need APC? cell? No? So how we have plasma cells? So we need B cells because TLP2 produce IL-4, stimulate B cells to the plasma cells produce IgE. So we need B cells. We need Ig or not?
Yes, sir.
What about mast cell?
Yes, sir.
What about neutrophil?
No, sir.
So neutrophil is not necessary in type 1 hypersensitivity. Ig molecules attached to what? Okay, mast cells by the constant region. The third question. Histamine released by the mast cell leads to all of the following symptoms except capillary dilation. Is it true or false?
True.
Airway constriction.
True.
Okay. Which one is not true? Mucus secretion. So if you have allergic rhinitis, you have mucus secretion.
Yeah, mucus.
High fever.
High.
You do not expect fever in a patient with allergic diseases. The next one. For hypersensitivity reaction to blockade, 2 bound Ig molecules on the mast cell must react with a specific antigen. True or false? It's true. It's true. And the last one?
True, sir.
It's
Yes, sir.
true.
Yes, sir.
Okay.
Yeah, true.
Okay. So let's have a look at animation without any sound. I mentioned that Ig has 2 parts of the FC part and the variable region. And please imagine that the allergen is getting by the APC, antigen presenting cell, and it process and then present by MHC. Okay. Then TLP2 get the allergen and present it to B cell. So B cell stimulate, proliferate to plasma cell to produce IgE. So this is cytokine. So we have now plasma cells and produce IgE. And IgE from the FC part attached to the surface of the FC, to the mast cells. So now the mast cell is sensitized. So when we have second exposure to allergen, second exposure, you can see that allergen attached to the variable lesions of at least 2 IgE, and we have some deformity in the surface of the mast cell, and then we have histamine release. So the histamine release leads to capillary dilation, hypertension, mucus secretion, airway constriction, itching, but not fever. Okay, was it clear? First part, it's about the type 1 hypersensitivity. Let's move forward with I will put all the animations here so you could get it see it in this evening. Okay, so I mentioned that there are some differences between type 2 and type 3 hypersensitivity. What was the difference?
Type 2 antibody directly connects into
Type 2
complex. It makes antibody
Type 2 is complex.
complex.
Type 3.
Complex.
What about type 2?
Directly
Attached to the surface of a cell or tissue or even receptor. Okay? So there are different types of three different mechanisms of type 1, type 2 hypersensitivity. In the first mechanism, antibody attached to the surface of a cell or cell, and then we have opsonization or phagocytosis. So antibody attached to the surface of a cell, we have opsonization and phagocytosis. The second mechanism, antibody attached to the surface of a tissue, complement health, and we have inflammation. The third mechanism, antibody attached to the surface of a receptor, either stimulated or blocked. Is it clear? So in all these mechanisms, antibody goes to the cells, tissue or receptor, and we have some reaction. So let me explain more about these three mechanisms. The first mechanism is about opsonization and phagocytosis. Please imagine that we have some red blood cells, RBC, and autoantibody attached to the surface of RBC. And then we have opsonization and phagocytosis, hemolysis. We say autoimmune hemolytic anemia. What does it mean? What anemia? Anemia.
Hemolytic.
Lack of RBC, low hemoglobin. Okay? What is autoimmune? What is hemolytic?
Breaking down cells.
So autoimmune hemolytic anemia. We have RBC, autoantibody attached to the surface of RBC, and then opsonization and phagocytosis. This is the mechanism. The second disease, this is autoimmune thrombocytopenic purpura. What is thrombocytopenia? What is thrombocyte? Platelet. Thrombocytopenia.
Degrees.
Okay, thrombocytosis means high platelet. Thrombocytopenia, low platelet. So we have platelet, autoantibody attached to the surface of platelet, and then opsonization and phagocytosis. This is the first mechanism of type 2 hypersensitivity. You know that we have blood group.
Yes.
Okay, so all of us have blood group A, B, O, C. Okay?
No, sir.
Oh.
A, B, O, C. What's the type of your blood group? C? Not C? Are you sure your blood group is C? Okay, we do not have any blood group C. So we have A, B, or O. Okay? So if I have blood group A, what should I have? Anti-B. So if I receive blood group B, what will happen? I have anti-B attached to the surface of the blood group B, and then opsonization and phagocytosis, hemolysis. This is again first mechanism of type 2 hypersensitivity. Was it clear?
Yes, sir.
Okay. So this is the first mechanism. The second mechanism is inflammation. There is a disease with antibody-mediated glomerulonephritis. What is glomerulus?
Kidneys.
The kidney. Okay. So antibody attached to the surface of tissue, glomerule, and then we have antibody-mediated glomerulonephritis. Itis means inflammation. Okay. And the third mechanism, I mentioned that antibody attached to the surface to the receptor. Okay. So we have thyroid gland and TSH, thyroid stimulating hormone, is responsible for producing T3, T4 from thyroid gland. Okay? So please imagine that we have autoantibody which mimic the TSH. So it attaches to the TSH receptor at the surface of the thyroid gland and make hyperthyroidism. It stimulates thyroid gland. We say Graves' disease. So we have exophthalmia. We are nervous. We sweat a lot. We are thin. Okay? Because T2, T4 are catabolizer. Was it clear? So autoantibody attached to the surface of a receptor and stimulate the gland. Okay? In contrast, we have some autoantibody and could block live acetylcholine receptor in the surface of the muscle. So it leads to myasthenia gravis. So they have ptosis, they have muscle weakness, so this is myasthenia gravis. So autoantibody could attach to the surface of the receptor and stimulate or block. Another disease, we have a disease with the name of pernicious anemia. Did you hear about pernicious anemia?
Yes,
What the disease?
Vitamin B12.
Anemia.
Okay, so we have intrinsic factor at the end of the duodenum. So it's responsible for absorption of B12. So if we have autoantibody and block the intrinsic factor, it cannot absorb. So we have megaloblastic anemia. RBC is getting MCV and MCH is getting large. So when we have microcytic anemia, it means that RBC is very small. Okay? So it usually has two reasons. One is iron deficiency, and the second one is thalassemia. When we have megaloblastic anemia, the main reason is pernicious anemia. It's because of the B12 deficiency. Okay? So when we visit a patient with the megaloblastic anemia, pernicious anemia, what do you prescribe? Only B12 tablet or B12 tablet plus folic acid? Which one?
Intrinsic factor must be present.
So which one?
Folic acid and B12 is same.
Both.
Both?
No,
Or-
B12.
The
Both.
patient with pernicious anemia referred to your clinic. You are planning to treat the patient. Are you just prescribe B12 tablet or B12 plus folic acid? What?
It was because of the deficiency of intrinsic factor. That's why it was not absorbing, right, sir?
Yeah. So what should we do?
B12.
Both.
Both?
B12 also. B12, sir. Which
Only B12.
is where the deficiency.
It cannot, the patient cannot absorb
Absorb.
B12. We should inject B12. Okay, so the answer is not about the B12 plus, acid folic or not, or alone. It's about the route of receiving the light. So if you prescribe B12 tablet plus acid folic plus zinc, selenium, it doesn't matter. We should prescribe B12 ampoule injection once per
Intermittent.
month because it cannot absorb. Was it clear?
Yes, sir.
Sir, because of lacking intrinsic factor, it was not absorbing, right, sir?
They
If we
cannot
give,
absorb from the drug, from the food, so they cannot absorb B12.
why they cannot absorb, sir?
Because the intrinsic factor is blocked by autoantibody.
If we give that type of drugs, sir, it will unblock that intrinsic factor.
If we can do, yes, but it's not easy. Okay, so we have another disease with the name of rheumatic fever. Did you hear about rheumatic fever?
Yes.
Yes, sir.
So what's rheumatic fever? It's not arthritis. That one is rheumatic arthritis. It's rheumatic fever. When you were, at the age of childhood and get streptococcal pharyngitis, your parents just warn you that you should receive penicillin. Otherwise, you might have mitral regurgitation. It's because that the antigen of the streptococcal mimics the mitral valve. So if we have antibody against the streptococcal, it could attack to the mitral valve and leads to mitral regurgitation and mitral stenosis. This is rheumatic fever. So please have a look at the list of type 2 hypersensitivity. I mentioned that autoimmune hemolytic anemia and autoimmune thrombocytopenic purpura are both type 2 hypersensitivity. Which mechanism?
What's it?
First two.
Opsonization and
Phagocytosis.
phagocytosis. There is another disease with the name of pemphigus vulgaris. We have bullous lesion at oral cavity, at mucosal line. Good postural syndrome. It leads to nephritis and lung hemorrhage. Again, it's type 2 hypersensitivity. I mentioned that acute rheumatic fever could be type 2 hypersensitivity. Myasthenia gravis. We have autoantibody against acetylcholine, and it stimulates the receptor. Was it true? Block. And what muscle weakness, okay, ptosis. And in grave disease, we have hyperthyroidism, we have autoantibody against TSH, and it blocks the TSH receptor. Okay?
Boost the stimulates.
Stimulate, exactly. Stimulate the TSH receptor and leads to hyperthyroidism. I mentioned pernicious anemia, which block the intrinsic factor, and there is another disease which you do not know the name, diabetes mellitus. Okay? So you know that diabetes mellitus usually have two types, type 1 and type 2. Type 2 diabetes seems to be type 2 hypersensitivity because this is insulin resistant. It means that it blocks the insulin and cannot, usually the adult, they are insulin resistant, type 2 diabetes, and we usually prescribe tablet. But in type 1 hypersensitivity, in type 1 diabetes, which is usually seen in the children, we usually prescribe insulin. Why? Because this is type 4 hypersensitivity. I explain it later. The beta islet cells are getting destroyed and we need insulin. So type 2 diabetes could be type 2 hypersensitivity. Okay. I have also animation for type 2, but I will not show it, just pass it to you to see it later because this is it's based on the blood group AB and ABO and show that how they can make reactions. So I will put it here and then you could see it later. So let's ask you a few questions about type 2 hypersensitivity. Okay, when type B is given to a person with type A, what will be happen?
Alpha.
A, sir.
A, sir.
Which one?
A.
A. The next one. True or
False.
false?
Anti-A, anti-B. You must have.
Patient with blood group O, are they universal donor or not?
Yes.
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 Blood group O are universal
Neither
donor.
A or
The next one.
false.
It is not universal. This is B.
False, sir.
It's false.
False.
Okay. So let's move forward with type 3 hypersensitivity. I mentioned that type 3 is immune complex. It was the difference between type 2 and type 3. So the small complexes are usually not phagocytes and go to the kidney, joints, vessels and deposit there. There are a few diseases in type 3 hypersensitivity. The first one is SLE, systemic lupus erythematosus. So this is systemic disease. So immune complex go to vessel vasculitis, go to the heart, leads to pericarditis, go to the glomerulonephritis, go to the skin, malaria, photophobia. So it's systemic disease. Okay. The second disease is polyarthritis nodosa. It's usually after the hepatitis B infection. The next one, post-streptococcal glomerulonephritis. You might remember that in type 2 hypersensitivity I mentioned that streptococcus mimic the mitral valve and lead to rheumatic fever. Excesses of streptococcus and antibody make immune complex go to glomerule and make glomerulonephritis. So streptococcus leads to two types of diseases. In type 2 hypersensitivity, rheumatic fever. In type 3, glomerulonephritis and serum sickness. This is a patient with SLE, systemic lupus erythematosus. That one is polyarthritis nodosa. You can see that the excesses of the viral antigen make some complication as vasculitis. And this is serum sickness, which leads to vasculitis, nephritis, and arthritis. We have also a term of Arthus reaction, which is a localized form of subcutaneous injection of an antigen. So in the past, they inject an antigen subcutaneously, experimentally, and showed that it makes an immune complex and leads to vasculitis. So there is an animation, but I believe that we need to see this animation. Have a look at type 3. You can see that antigen and antibody make an immune complex. Immune complex go to the small vessels. Intermediate size immune complex go to the small vessels. Then complement help them. Then the basophil come and make some vasodilation, and then this immune complex attached to the surface inside of the vessels. Again, complement helps, and then neutrophil degranulate and make some lesions. This is the mechanism of the type 3 hypersensitivity. Okay. Question. What is immune complex? Very simple. Antigen plus antibody. Intermediate size complex. If you remember the animation. Activate complement. Complement help. And after complement activation, basophil may degranulate, causing vasodilation.
Neutrophil vasodilation.
Not the same. Neutrophil, basophil, mast cell, all of them
true.
to degranulate. So it's also true. Okay, so I just finished type 3. Let's move forward with type 4 hypersensitivity, the last type of hypersensitivity disorder. If you remember from the beginning of the class, I mentioned that in type 1 hypersensitivity, TH1 has the main role.
TH2.
Okay. But in type 4 hypersensitivity, TH1, TH2, and CD8 positive cells.
So is not
TH1, TH17, and TH2.
No,
TH1, TH17, and CD8 positive cells have the main role in type 4 hypersensitivity. You can see that there are two mechanisms. The first one is cytokine-mediated inflammation, and the second one is T-cell mediated cytotoxicity. So, IL-17 hormone neutrophil recruitment, interferon gamma produced by TH1 activate macrophages, and TNF-alpha is responsible for activation of the leukocytes. There are a few diseases in type 4 hypersensitivity. I can name a few of them, like rheumatoid arthritis. So do you remember that rheumatic fever belongs to which type of hypersensitivity? Type 2. But rheumatoid arthritis is type 4. Multiple sclerosis, type 1 diabetes is type 4 hypersensitivity. What about type 2 diabetes?
Type
Type 2 hypersensitivity. psoriasis. So all of them are belongs to the type 4 hypersensitivity. There is some reaction we say contact dermatitis. For example, if you walk to Fish Island and find some local street, even if you go to Pakistan, to India, you can see that there are small shoppers, metal, something they are selling. For example, 3 Rolex watch, just 100 rupees, something like that. Okay, very cheap. And then 48 hours later, you start, pruritus, rashes. This is the contact dermatitis to metal, to some fake metal. Okay, this is contact dermatitis. It's also true when you wear latex gloves. Okay, some of the people have some reaction to the latex glove. Again, this is type 4 hypersensitivity because it doesn't start immediately. It starts 24 hours later, 48 hours later. It's delayed type hypersensitivity. This is cell-mediated immune. And we have also a disease, IBD, inflammatory bowel disease. Have you heard about IBD? So there are 2 types of IBD, Crohn's disease and ulcerative colitis. So it's a bowel, gets some lesions and they have some bleedy diarrhea. So this is inflammatory bowel disease. Again, this could be classified as type 4 hypersensitivity. Did you hear something about PPD? Did you hear something about tuberculosis? No?
Yes.
Okay, you know that they usually vaccinate with BCG. Okay, BCG. Didn't hear? You didn't vaccinate with BCG at childhood?
Yes.
Okay, so it's just for protecting you against, brain or miliary tuberculosis. There is a test, we say PPD. Okay, so they just inject the purified protein derived, and 48 hours later, read the induration, not redness, induration, a stiffness. It shows that are you affected by tuberculosis, are you protected by tuberculosis, and we say this is again delayed type of hypersensitivity.
What is the name of this?
PPD, purified protein derived, PPD. I might find the name, yes, here. Can you see purified protein derived, PPD. Okay, so if we have a look at the diseases of type 1 hypersensitivity, you can see that there is rheumatoid arthritis. The cells which are responsible for rheumatoid arthritis are TH
1, 17 and
17
CD.
and 17. Let's have a look here. TH1 and TH17. I mentioned earlier. Multiple sclerosis.
Again, take one.
Again, you can see TH1 and TH17. But in the diabetes mellitus type 1, this is CD8 positive cells. CD8 positive cells destroy the beta islet cells. So that's why they cannot produce insulin. So it's different between type 2. In type 2, this is insulin resistant, type 2 hypersensitivity. But in type 1 diabetes, we have CD8 positive cell and destroy the beta islet cells. IBD, inflammatory bowel disease, and psoriasis. So there are different types of type 4 hypersensitivity. So this is a patient with rheumatoid arthritis. You can see that the patient has deformity of the joints. Is it clear? And in multiple sclerosis, again TH1 and TH17 have the main role in multiple sclerosis, diabetes mellitus type 1, and this is IBD. Am I right? Is it IBD?
Psoriasis.
Psoriasis is a skin, not bowel. Okay, so this is psoriasis. This is a skin lesion. But both are type 4 hypersensitivity, and this is the PPD test. And there is another disease which we name GVHD, graft versus host disease. When you transplant, it could be rejected just after 48 hours, and this is the delayed type of hypersensitivity. So let's have a look at the animation for type 4. It seems that it's also getting tired, like you. Immunity type 4 hypersensitivity, again, you can see that when an antigen comes, you remember that in type 1, TLP2 get the allergen, but now TLP1 has available. So please imagine this is contact dermatitis. When we face a poison of a leaf, plant. So the Hopton help and help the carrier come to the macrophage, then it processes the antigen and presents it via the MHC again. Then theater 1 get a stimulator and proliferate. When we have second exposure, again you can see that in type 4 we need second exposure. So we have a cytokine release, then go to the macrophages and the mediator of inflammations, and you can see that it leads to some skin lesions. Okay, is it clear? By the way, I will share with you the clips and you can see them again this evening with voice. Okay, let's ask you a few questions about type 4 hypersensitivity. So on first exposure to antigen, TLP cells which one is
Alpha
become
activated.
activated and increase in number. Question number 2.
Beta
Charge.
48 hours. 48 hours.
48 to 72 hours.
Yeah.
Who agree with B? 1, 2, 3, 4, 5, 6, 7. So what about you?
C.
Why?
And second exposure.
Exactly. I mentioned that second exposure is needed. So it doesn't matter that it's very accurate 48 to 72 hours. But I mentioned that first exposure is not true. It should be after second exposure. So 24 hours after second exposure, and delayed type of hypersensitivity is due to effect of the humoral part of the immune system. Is it true or false?
False.
False.
Cell-mediated.
It's cell-mediated, exactly. Okay, thank you very much. So let's get back to sensitivity and which disease. Top left, what's the name of disease?
Rhinitis.
Exactly, allergic rhinitis. Type, type,
One.
type 1.
One.
It's allergy. Type 1 hypersensitivity, IgE mediated. Let me top middle. It's eczema. It's atopic dermatitis, eczema in infant.
It's type
One. One.
And one was
One.
contact dermatitis, psoriasis. But eczema is type 1 hypersensitivity. Top right, it's anaphylaxis, angioedema, it's emergency. So the patient has angioedema, then breathing, hypertension, so it's emergency medicine. Again, this is
Type
systemic form of
Type
type 1
1
hypersensitivity. This one. After eating a few bites of peanut cookie.
Yeah, food poisoning.
It's
One
food
sip,
allergy.
one.
Again, 1. And the last one,
Caffeine, asthma,
allergic
bronchitis.
asthma and type 1 hypersensitivity. Okay. Let's have a look at the second slide. Top left,
Ptosis.
asbestos. What's the name of disease? What? What's the name of disease? Those two. Myasthenia gravis. And it against acetylcholine receptor. And it stimulates the acetylcholine receptor. Okay? Block. So it makes to muscle weakness. Ptosis. Top middle. Top middle. It's pemphigus vulgaris. Again, type 2 hypersensitivity. Top right,
Lupus.
type systemic lupus erythematosus. And type 3. It's immune complex. Go everywhere and make reaction. This one. Graves' disease, and this is hyperthyroidism. Type 2. And which mechanism?
Directly
Attached
attached
to the
to
receptor of TSH and stimulates.
More and more.
This one.
Rheumatoid
Rheumatoid arthritis type 4. Psoriasis type
4.
4.
4. Type 4 hypersensitivity. Okay. In summary, type 1 hypersensitivity is Ig mediated, immediate reaction, and TLP2 has the main role. In type 2, antibody attached to the surface of a cell, tissue, or receptor and make a reaction. Type 3, we have antibody antigen, immune complex and go to the reaction. And type 4 is cell mediated, Th1,
17 and CD8.
and CD8 positive cells have the main role. So what I mentioned in my first class is from the chapter 19 of Abdullah Bostek's book, and my question is from what I mentioned in this class, which is based on the chapter 19 of Abdullah Bostek's book. If you are interested in the field of allergic diseases, autoimmunity, and immunology, I had the chance to publish 3 volumes of the pediatric allergy, pediatric immunology, and pediatric autoimmunity and transplantation into more than 2,000 pages by Springer. It's just MCQ. So it's just cases and studied question. I will definitely ask no question from this book because it's not your reference, but if you are interested, you could have a look at these books as well. So